Kia ora koutou, ko te tirangi te maunga, ko te ranganui te awa, ko Ngāti Pākehā te iwi, no Tairawhiti aho, ko Tairawhiti taku tūranga waiwai, ko Nicola Kayes taku ingoa. Welcome, thank you for having me everyone. I always find it a real privilege to be able to come and talk in these kinds of settings. The only reason I do research is in order to make a difference in the real world. To me, this is a really good opportunity to share some of the work that we've been doing and hopefully make a difference in the way you think about and deliver your services within community rehab at ADHB. And so, as Rebecca has said, she shared with me this statement from the business plan, and I've kind of shanked the presentation today around not necessarily telling you the answers, because I'm not sure there is a perfect answer to this question. In fact, I think we are often at risk of oversimplifying this kind of statement. And so, if anything, probably I might hopefully provoke some thinking about this topic and help you consider what that means for the way you deliver services within your community rehab teams. So just to get started, I thought I would tell you just a really brief little amount about the Centre for Person-Centred Research and who we are and what we do, just to give you a sense of where we come from. So we've been around since 2005. Originally we were established through the leadership and appointment of Professor Kath McPherson, who was appointed at AUT as a Professor of Rehabilitation in 2004. And so I was appointed by her as a research officer at the time, and I still remember sitting around the table in her office thinking, how do we make what we do visible to people, and how do we distinguish ourselves from the other research that's going on at AUT, which at the time was very much driven by physiotherapy and was mostly very impairment-based or function-based. And so we were thinking, what distinguishes the work that we do from the work that they do? And that's when we started talking about ourselves as focusing on person-centred rehabilitation. So that's where the person-centredness comes from, and that has stuck because it still very much gives a sense of who we are, the values that we bring to the research that we do, the way we conduct ourselves as researchers, but also our interest in embedding person-centred practice within health services in New Zealand and globally. And so we have three core interrelated purposes. All of them are fairly action-oriented in some ways. So we talk about rethinking rehabilitation, and what we mean by that is really challenging some of those taken for granted assumptions, particularly around those core rehab processes. So goal planning, therapeutic relationship, behaviour change, some of those core rehab processes that are not necessarily specific to a discipline, but actually which transcend those disciplinary boundaries. So a lot of our work is about really challenging what we know and understand about those core processes as critical to outcome, and how we can optimise outcome by focusing on those in a little bit more of an active and targeted way. We talk about embedding person-centredness. So how do we truly embed a person-centred way of working and person-centred cultures of care in the way we work with people and the way we structure and deliver services? And most importantly, we do this because we want to make a difference for people living with the long-term consequences of injury and illness. And so our primary goal is, what can we do to improve outcomes that matter to people who are living with the long-term and enduring consequences of injury and illness? And so our focus on rethinking rehab and embedding person-centredness ultimately is to focus on that as an outcome of importance. And so we have a range of core research themes, what you can see up on the slide, and we also have worked quite hard to think about what are the values that we bring to the research that we do, and so the values are along the bottom of the screen. So this is the statement that Rebecca referred to in the business plan. So your goal is to provide quality, patient-centred, self-directed care closer to home. So I'm going to really focus on the patient-centred and self-directed part of this statement today, and share with you some of the thinking that we've been doing around some of these topics, but also give you some examples at the end of some of the research we've been doing to try and look at these and consider how we might practice differently in light of the research that we've done. So I guess the first thing to say, so focusing on person-centred or patient-centred first, I guess, is the language, and I'm going to talk about the language a little bit in a moment. You're not alone, right? So this rhetoric of person-centred rehabilitation is embedded in just about every strategy and guideline and service delivery document throughout healthcare in New Zealand and around the world. So we see this language everywhere. We see this language in strategy documents, we see it on websites, we hear people talk about it from a disciplinary perspective. So in occupational therapy, for example, if you look at how occupational therapy defines themselves, person-centred is in the statement that talks about what occupational therapy is. So you're not alone. This language is used all over the place. Alongside that, we have this pretty extensive and growing body of research that tries to then make sense of what is person-centred practice, what does it look like in practice, what gets in the way of it, what can support us to work in a person-centred way more readily, what makes it possible, what constrains it. So there's a massive body of literature and evidence out there on this topic. And there's also a professional commitment. And so last year, anyone who is part of Physiotherapy NZ will know that they released, for example, this model of person and whānau-centred care for Physiotherapy New Zealand to really inform how physiotherapy thinks about this topic. We see it in occupational therapy, code of conduct and standards. The same is true for other professions, speech and language, nursing, and others. And so this rhetoric is everywhere. The question for me is, to what extent is that rhetoric really translated into reality in the way we work and function, not just as individual practitioners, but also in terms of the systems and structures that constrain or make possible the way we work as practitioners in practice. And so this is a topic that I think about quite a lot. I talk to a lot of people about, and I've done a lot of research really focusing on and trying to understand this. And there are a few things that I think get in the way of us really translating this rhetoric into reality. The first is that we really lack good definitional understandings of what person-centred practice really is. We also lack good understandings of how to operationalise that in practice. And so we have hundreds of frameworks and models and different ways of thinking about what that should look like. And it's really hard to see the wood for the trees in some ways around what is it that we're doing and what might that look like for us as a service or for me as a practitioner. And so what we see is we also see these campaigns that come out. So how many people have heard of things like the Hello, My Name Is campaign? Yeah, so a few nods. How many people have heard about the What Matters to You campaign? Yeah? So the Hello, My Name Is campaign was started by a physician in the UK who had a diagnosis of cancer, and when she was on the other side of the house service, it really concerned her that she felt very much like no one really understood her or who she was as a person. Mostly, people didn't acknowledge her as human at all. And so she started this campaign of, actually, sometimes it's about the really simple things. Just introducing yourself when you walk in the room. So before diving into business, hello, my name is. And so that campaign has grown and has gone quite global. She's since passed away, but her husband is now continuing on that campaign. The What Matters to You Day is a campaign started in Scotland that was about really trying to say, we have a day that is about what matters to you, what matters most to you. We ask that question. My concern about all of these campaigns is that should we need a campaign to remind us that we're working with human beings? Probably not. We shouldn't need a campaign to do that. Secondly, what they do is they boil person-centred practice down to sometimes very transactional things instead of stepping above and thinking, how do we truly create a culture of care that is person-centred? And so if we focus just on the transactional tasks that we do, sometimes we get it wrong because that means that we're assuming that person-centred practice is always about this. Whereas actually we know that people have different needs and preferences. They require different ways of working. We need to figure out what does person-centred practice mean for this person in this context. The second thing is that we underestimate the complexity. So we think about it as something that is, well, yeah, of course, we do person-centred practice. And I talk to many people who say, well, yeah, of course we do person-centred practice. We think that's really important. And I agree that everyone shares a keenness to do person-centred practice. I think the values of person-centred practice resonate. And I think they probably resonate with all of us as health practitioners, because it's one of the reasons we came into a profession like this is because we care. And so the values of person-centred practice resonate for us as people. However, the problem with that is that we think about person-centred practice as something that we either do or we don't do. Whereas actually, if we thought about person-centred practice as something that sits on a continuum, that we can always be doing a little bit better or a little bit more or a little bit differently, then that means that we are engaging with person-centred practice in an ongoing, reflexive, enduring way. So we've never reached the destination. There's always more that we can be doing to do it even better. So I think we all sit on a continuum of person-centred practice. And I just think all of us, no matter where we are on that continuum, could be asking the question, what can I be doing a little bit differently to move just a little bit further along that continuum? So this quote here is from Brendan McCormick, who's quite a big name in the field of person-centred nursing. So he's based in Scotland, in Edinburgh, and has a research centre that shares a name that is almost identical to our own, but focuses on nursing in particular. And he talks about it's enabled by cultures of empowerment that foster continuous approaches to practice development. And I think the key there is cultures of empowerment. In other words, structures and processes need to support the way we work, need to support us to be ongoing, reflexive in an ongoing way on this topic, but also that they foster continuous approaches to practice development, that we're always critically reflecting on what we're doing, why we're doing it, and how we can do it differently or better. Thirdly, and I've already implied this several times, people like Brendan McCormick would argue, and there are quotes along these lines in most of his writing, that sometimes the systems and structures in which we work are inherently unsupportive of person-centred practice. And so even when we want to work in a particular way with a person, we can sometimes feel constrained by the systems and structures around us. And so person-centred practice is not just about what individual practitioners do, but also about the structures within which they sit and the processes that become our scripts for practice, how they can embed and support and make possible a person-centred way of working. So Avidas Donabedian, as a philosopher that has done a lot of work, or many moons ago, did some work around what constitutes good quality care. And Donabedian argues that for good quality care to be delivered, you need to think about structure, process, and outcome. So if the outcome you want to achieve is patient-centred, self-directed care, you need the structures and processes in place to support that process. And then, of course, we all know that the biomedical model is very dominant and strong in the way we function and deliver health services in New Zealand and around the world. And alongside that, it is also very heavily informed by a Western model of health service delivery as well. And so the way we think about things like professional boundaries are not necessarily transferable across cultures, for example. We tend to emphasise on impairment and activity, but we often fail to recognise psychosocial wellbeing in the way we work with people. So I did some research a couple of years ago looking at following up people a year following significant trauma. Many people, the things that sustained the ongoing problems that they were having were often psychosocial in nature. None of those people were routinely given any kind of service that would help and support and manage their psychosocial wellbeing. The people that did access those services because they had asked for them and they had sought them out, not because they were routinely offered or delivered. So we routinely minimise the psychosocial impact of long-term injury and illness. and therefore people live often with very long-term effects that are exacerbated by the psychosocial response. So those are just some of the things that I think mean that we don't always do a great job necessarily of translating rhetoric into reality. However, I want to emphasise the continuum of person-centred practice, because I think that makes it sound like we're not doing it at all, and I don't think that's true. Whereas I think we are all on a continuum, but how can we move along that continuum? One of the things that these things lead to is this idea that I kind of call conditional person-centred practice. And so I'm going to share with you some quotes from practitioners that we've worked with over the years. And so, for example, what I mean by conditional person-centredness is we are person-centred, but it's important people are realistic. So she did have a lot of goals around her mobility, which were really difficult, though, for the physio to manage, because there weren't really realistic things she wanted to be doing. So we're person-centred, but people need to be realistic. We are person-centred, but we make assumptions. So he's got a lot going on in his head, sort of brain injury-wise. He's not going to want to borrow this. So we make decisions on people's behalf quite often. We are person-centred, but we've got a job to do. So some of the questions are very sensitive. So at times you're like, I don't know if this is actually the right time for me to ask this, but that's, what we do on our first visit. And so this is a speech and language therapist who, they go out on their first community visit and they've got a range of scripts for practice, things that they need to do because that's what you do on your first visit. In this case, it's getting the person to complete some outcome measures. And some of the questions in this measure feel like it's just maybe not the right time to be asking these questions, but it's what I do on my first visit. So even though I recognise that this might not be the right time to ask these questions, I'll do it anyway, because that's what the system tells me I should do. We are person-centred, but we want to avoid opening a can of worms. I was a bit concerned about how my client would actually respond for the simple reason that he had a lot of social things going on in his life, and I just wondered whether it unearthed stuff. So there are often, I would say, that rehabilitation is always delivered in a psychosocial context. There are always things going on for a person that can get in the way or not of the work that you do. And so when we ask about the concern about, but I don't want to open this can of worms, what we need to know is that the can of worms is there whether we open it or not. So whatever is going on for that person is necessarily going to influence what goes on for you, whether or not you open that can of worms. And so absolutely, we work in an interdisciplinary team, right? Or we should work in interdisciplinary teams. And actually we recognise that each person within that team has unique and specific skills to contribute to rehabilitation for that person. So we should be drawing on all of those skills, and people bring particular specialty, understanding, and can help navigate some of these processes. One of the things that I would say though is that doesn't mean that physios, OTs, speech and language therapists shouldn't be interested in understanding the psychosocial context. You can't do your job well if you don't understand what is going on for that person. So if we just assume that the person's going to go through with that home-based exercise program, but we haven't really negotiated and understand the context that is going on for that person, then we can't tailor that program to them. They're probably not going to do any of it at all. So we need to also all be interested in. Doesn't mean we suddenly become social workers or we suddenly become psychologists, but we do need to understand what is going on for people in order to work best and tailor care for them. But it's complex, right? So what person-centred looks like as a way of working can vary from person to person. So for one person, it might be really actively engaging them in the process. For another person, it might be giving them space and time and doing a little bit for them. If we focus on only saying that person-centred practice is always about actively involving the person, then what do we do when people don't have the cognitive capability to actively engage in the process? Does that mean we give away person-centred practice? Probably not. So it's not about particular things, it's about a culture of care and embedding a philosophy of practice that is focusing on who is this person and what matters most to them and how can I meet them in the middle. Oh, here's a great quote that just really nails exactly what I've just said. So this quote here is from a paper where they were asking and interviewing practitioners about person-centred practice and how to implement it. And essentially this quote is talking about the right client for person-centred practice. So the right client is someone who's cognitively intact, has very good judgment, probably already has some pretty good insight into how they're functioning within their environment. I guess along with that, someone who has pretty good problem-solving skills already. How many of your clients meet this? Probably none, in fact, when you think about it. And so if person-centred practice means that people have to meet this yardstick in order to really actively and feel engaged in their care, then we may be missing the point of what person-centred practice is. And so we need to move away from these fixed assumptions of what person-centred practice is, and we need to really think about it more as this culture of care. And we need to think about it as a reflexive, nuanced way of working, informed by the question, how do they need me to work? And we need to be asking questions like, how can we meet people where they're at? So it's about meeting people in the middle. It's not about giving away the disciplinary skills and the breadth of knowledge and experience that you bring, because of course that is critical as well. But it is about finding a way to bring those skills and experience to that person in a way that can truly support them to get the best outcomes that you can. Okay, so that's person-centred. What about self-directed? So again, you're not alone in thinking about this kind of thing. Again, this is something that we see, and we see increasingly in strategies and business plans, and particularly in the context of an ageing population, in the context of more people living with significant consequences of injury and illness. We see this rhetoric coming through a lot as well. So we do a really excellent job of saving lives, and we're getting better and better at saving lives. But what that means is that we have a significant amount more people living with the long-term consequences of injury and illness that need active support and management, oftentimes for a lifetime. And we don't have enough resources to necessarily manage and work with people actively for a lifetime, and so often we need to really think about ways in which we can support them to grow capability to manage their condition in the long term without active input from rehabilitation service or other medical professions. But to what extent, again, do we do this in practice? So we've done a little bit of work in this area, but Susie Mudge, who is a physiotherapist who owns a neuro rehab clinic on the North Shore, but also works part-time with me as a postdoc at AUT, is really interested in this topic. So Susie's doing quite a lot of work in this area. And a while ago we synthesised a whole range of evidence that is already out there about how clinicians view their role in self-management, for example. And one of the things that resoundingly comes through is this tension that we have as practitioners about letting go of control. So we want people to self-manage, but we also think they should do it this way. Or we also want them to understand that we know the literature and we know what is best for them, and we want them to do what we think is best for them. So we really struggle to let go of that control. We also have a lot of expert knowledge that we can contribute, but oftentimes we privilege that over the expertise that patients can bring to the party as well. And so one of the things that I always say is, we have expertise maybe in the physiology of the condition and what we know is the best evidence treatments for that condition, and we can maybe, because we have years of experience of working with this population, we also have gathered over the years cumulative evidence about what we think the future might hold for this person that we can apply in their situation. So we have a lot of expert knowledge, right? But they know themselves, they know what's important to them, they know what their experience of living with that condition is and what the implications of that are for them in their future. We need to know and understand that as much as we need to know and understand our expertise so that we can bring that together to really optimise outcomes for them and outcomes that matter to them. The other thing is that there's this tendency to kind of use this language of self-directed as a tool to blame patients when things go wrong. And I'm not saying that we even do this consciously, but you can see all through the literature, for example, and you hear this in my postgraduate classroom. We have these conversations all the time. So when one of my papers is a paper called Innovative Strategies Engaging in Rehabilitation, and I always get all the students to introduce themselves at the beginning and say what brings them to this paper. And the kind of things you hear at the start of this paper is, well, yeah, no, I really struggle. Like sometimes patients are just really complex, they can be really difficult, and I really need to know how to manage those patients. Or, you know, I just really struggle with compliance, and, you know, people really need to comply, and so I just really need some strategies that can help people comply. So we have language like patients are unmotivated, they're not compliant, they're difficult. We have that language in the way we talk, probably in the clinical case notes that you have. You see this language probably being transferred across the team as well. And we have it all through the literature as well. And so we have this tendency to blame patients for failure, and the problem with that is that there's a lot that patients might be able to do differently, and there's a lot of interest in patient behaviour, and of course we need to understand that. But when we only focus on that, we miss the opportunity to look at ourselves and consider, how can we work differently with this person to increase the likelihood that they will be engaged in this process, to build capability for them to manage their wellbeing in the future. So we need to look also at the way we work and how we interact with people as a mechanism for supporting them in that process. Thirdly, we still have this tendency to focus on clinical indicators of outcome. And probably the best example I can give of this is within a diabetes setting, when we focus a lot on people self-managing diabetes, and the prime indicator of success in their management is their HbA1c levels. Did I say that right? Yeah. So we still focus on these clinical indicators of outcome, whereas actually when you talk to someone living with diabetes, they are normally managing a whole range of complexities. So they're trying to balance their blood sugars and their levels, but they're also trying to actively engage in a life that is really meaningful and important to them. And sometimes they know themselves pretty well, and sometimes they make explicit decisions about trading off between, how do I live the life that I want to live and the way that I want to live it, but also manage this in a way that feels okay and keeps me safe. So they might make trade-offs along the way. And so one of the things that an author in Scotland, so Heather Morgan and Vicky Entwistle, have done some writing on this topic of self-management in Scotland, and they talk about maybe we need to shift this rhetoric from managing the condition well to managing well with the condition, and how does that change the outcomes that we're focusing on as an indicator of success. And then lastly, one of probably the strategies that we have in our repertoire to support people to self-direct or self-manage their conditions is education and prescription. So we primarily draw on those as our key strategies to support people in this process. So we interviewed physiotherapists a while ago for a project who work mostly in private practice, asking them about what they thought their role in supporting people with osteoarthritis to self-manage was. And primarily, all of the quotes from physios are about education and prescription. So this is just one example here. So our responsibility is to set the program for them, to educate them on why they're doing those bits and pieces, so quite clear prescription. And then from there, my expectation is that they commit to that. So we use education and prescription routinely in practice, but actually we know, for example, from all of the evidence in behavioural psychology, that just having a goal or an intention to change does not translate into action. Also, education, there's more and more evidence that tells us that education alone is not sufficient to make a change to behaviour. And so what are the strategies that we're missing that we need to add to our repertoire more routinely to optimise the likelihood that people can translate those things into action? And so we may be missing the mark. Now, anyone who has heard me speak before might have heard me talk about self-regulation theory, and that's because I quite like self-regulation theory, and it's been around for quite a long time. Originally, Richard Seagate and Kath McPherson and William Taylor, all New Zealand-based researchers in the rehabilitation field, synthesised a range of theory around self-regulation to try and, in a nutshell, synthesise what the core assumptions of this theory are. And so these are the 5 bullet points that they refer to in their paper. The one in particular I want you to look at is the middle one here. Success in achieving desired goals is determined by one's own skill in regulating cognition, emotions, and behaviour. So if you think about that in terms of the behaviour that we maybe want to support as self-management, and in order to self-manage, people need to be skilled at regulating their cognition, their emotion, and behaviour. Think about that in the context of many of the people that you work with. So, for example, say someone with stroke, discharged from acute services, they might be living with significant physical impairment, they might be living with speech impairment, they might have some cognitive functions that have been impacted by the stroke, they might be experiencing significant fatigue, and alongside that, they are undergoing a psychosocial transition. So they may not be able to function and do the things that they used to be able to do before the stroke. They may have a significant disruption to their sense of self and identity, and so they're navigating the emotional journey of that alongside all of these significant physical, cognitive, and behavioural impairments. How likely is it that this person is able to regulate their emotions, cognitions, and behaviour without additional input, do you think? So people inherently, their ability to manage themselves might inherently be impaired by the injury or illness that they've experienced. Even some of the most mild injuries and illnesses that people experience might impact any number of those areas or facets that we need to regulate our behaviour. And so if we want people to build capability to self-manage or self-direct their care, then we need to actively and explicitly support them to build and rebuild their self-regulatory capacity. So these are just some examples of quotes from people who we've interviewed over the years. These particular examples, the cancer one and the multiple sclerosis one, are talking to people, for example, about navigating physical activity in the context of their condition. So the person with cancer, I was quite conscious in some bizarre way that my body had failed me because I'd had cancer. And it's one of those things you can't see. So that distrust in one's physical self when they're navigating physical activity. For the person with multiple sclerosis, it's like having a tin can with holes punched in it. No matter how much water you pour in, it's still pouring out. So even if you pour heaps more water in, it will still pour out, you'll never get anywhere. So this is a person with chronic progressive MS, and this person is trying to be physically active and follow recommendations, but actually they're feeling pretty helpless and hopeless because the speed of degeneration is probably quicker than the benefit of that physical activity. And so they're not experiencing the benefits, which makes it really hard to sustain engagement if you can't see the outcomes. We know as health professionals that in fact the physical activity might be maintaining function, and that in itself is a good outcome. But that doesn't necessarily help the person if they feel like they can't see the benefit. And so if people struggle to regulate their behaviour, then that in turn has cyclical effects in terms of their ability to engage in a rehab process. So progress or failure in goal attainment has affective and emotional consequences, and that cycles to impact on people's motivation and engagement. So if they struggle to regulate their behaviour, they're less likely to achieve goals and experience success. That's likely to have a negative emotional impact on them, and they're likely to disengage. Whereas if we can support them to experience success, build their self-regulatory capacity, then we improve their emotional response, and we're likely to have a more sustained engagement in a rehab process in the long term if we build that capability. What we tend to do though is we focus our energy in particular places. And so this is an example, this actually is an example if we were thinking about, say, a 21-day inpatient rehabilitation setting post-stroke as an example. So average length of stay is about 21 days in the inpatient setting, right? And so mostly the primary outcome of interest that we have in this setting is we want people to be safe to discharge, and the KPI that drives our practice is length of stay. So we want to reduce length of stay, increase safety for discharge. And so when those are our KPIs, what we do is we focus primarily on activities of daily living and reducing impairment in order to get the person safe to discharge. So in that setting, what we do is we think, right, we've got 21 days to work with this person. What can we achieve in 21 days? And that tends to be our focus. However, what that leads to is time-limited goals and outcomes. So what can we achieve in 21 days? A dominant focus on impairment and function as it relates to that impairment, as opposed to how it relates to long-term health and wellbeing for the person. That's when this conditional person-centeredness come in, because we have service-specific and disciplinary-specific goals to focus on that may not be the same as the goals for the person. We have limited opportunity to address multi-morbidity, so we focus on what is the person here for. They're here because they've had a stroke, let's focus our energy there. And we don't address multi-morbidity well at all. And we focus on the now, and so there's a lack of value then ascribed to thinking about the future and what that looks like for this person. If you look at it from the person's perspective and think about that little period there as just one little blip in their long-term journey, and that they have this lifelong journey of managing the ongoing consequences of this condition, imagine if we changed our KPIs and our outcome of interest. Imagine if, just for a moment, blue skies, I know, we threw away safety to discharge, not saying that that won't be part of it, but I know because I'm aware you're feeling anxious right now. Imagine if we threw away safety to discharge and length of stay as our KPI, and we replaced that, even in that 21-day acute inpatient setting, with our primary outcome of interest is long-term health and wellbeing for this person, and our KPI is simply that they have a healthful and meaningful life. How might that change what we do in that 21 days? How might that change what we value and the way we spend our time and what we legitimise as critical components of practice? So I asked this question in a workshop recently. I was playing with the idea of using creative tools to support people to think about this. It was the first time I'd done that. Not sure I was 100% successful, but it worked okay. And the left side there is what happens when our KPIs are safe to discharge, length of stay. What do we do? What are the things that we prioritise in our time? And so you might not see this well, but it says assessment, treatment, patient and family education, discharge planning, prescription, getting to know the patient's home context in order to know whether or not they'll be safe in that context. And then the second one there on the right-hand side is what if we blew it open and shifted the KPIs? And where would we then spend our energy? And here it says addressing the emotional needs, building therapeutic relationship, treatment, observation, behavioural strategies, and building confidence. So really different things that we are focusing on when we do it that way.
What do you mean by building a therapeutic relationship?
So meaning building the relationship between the patient and the practitioner.
It's really interesting. Psychosocial language comparison to it's like the language.
Yeah.
It's very interesting.
And of course there's a range of language that people use to talk about that in some ways. I use therapeutic relationships still partly because I think that inherently we're talking about a relationship that it can be therapeutic in its own right if you focus energy on developing positive relationships that build capability for the future. So again, it's complex, right? So people's ability to regulate their behaviour and engage in self-directed care may be impacted inherently by injury and illness. And so we need this more fundamental shift from focusing on managing the condition well to managing well with the condition. And we need to look at how we can optimise what happens at the point of care to build capability for health and wellbeing in the future. So what can we do differently here when we're with this person that might optimise long-term outcomes for them? So this is your goal, to provide quality, patient-centred, self-directed care closer to home. I haven't necessarily given you the answer to how you do that, but I guess what I've tried to do is provoke some thinking about what that could look like or what it might need to look like if you are to work in this way. And I think it's clear that it's more complex than we give credit. It requires active, explicit and ongoing work, and it may require a fundamental shift in how we deliver services. And that's not just in how individual practitioners deliver services, but more broadly, the structures and processes that underpin the way we work and are formative to the way we work with people in practice. And so I'm just going to, in 2 minutes so that we have time for some questions, orient you to some work that we're doing within our research centre to really try and tackle some of these questions. And they're just examples and the tip of the iceberg, really. So we've done quite a lot of thinking about person-centred practice. We recently undertook a secondary analysis of 10 years of qualitative data to really try and understand what person-centred practice looks like in neurorehabilitation, because a lot of our data is in neuropopulations. And we have a paper that reports on this framework, but essentially the point here is that it's trying to shift person-centred practice beyond those transactional things or particular fixed assumptions about what it means all the time, to really shifting it beyond that to more of a culture of care. And so I can always send the paper if people are interested in that paper to learn more about that. But I think the other thing that I will say is we deliberately use the language of person-centred, and I would say that we do that for 3 reasons. So instead of patient, the first is that a person is always more, inherently more, than a patient. They're a patient only because they occupy that role at that particular time, and that's the reason that you're working with them. But they are inherently more than a patient, and so when we're working with them, we need to think about the broader context of who they are, both in terms of their past experiences, their present situation, and their future possibilities. Secondly, a lot of people critique person-centred practice because it still kind of holds that individualised way of working and doesn't honour whānau-centred care or more collective ways of working. And I feel really strongly that we need to be thinking differently about practice to understand, for example, te ao Māori and what that means for the way we practice. The reason I still use person-centred is because I'm not talking about person as individual. I'm talking about person in terms of personhood, and personhood is always socially and relationally constructed and is always in the context of the person. So how someone's personhood is always in the context of their context. And so for some people that might mean a collectivist culture and whānau-centred. For other people that might not be the case. So person-centred, I think, allows for us to look at that in the context of personhood. And thirdly, when we talk about person, I'm not just talking about the patient, I'm also talking about the practitioners and the people within the health system that work in that way. And so I think that a person-centred culture of care should be mana enhancing for all. So it can't be just about raising the patient at the cost of the clinician. it needs to be able to raise mana for both the patient and the practitioner. And so when I think about person-centred cultures of care, it's also about how do we support and maintain health and wellbeing of people who are delivering healthcare and services. What does that look like? What does it look like when we're talking about delivering person-centred care for both patients and practitioners, for example? Secondly, we are doing a whole lot of work that's really trying to rethink core rehab processes. So we've got a long history of doing work, for example, in goal planning. I've done a lot of work looking at therapeutic relationship and what matters most in the therapeutic relationship and how do we optimise that in rehabilitation. How does that differ, for example, from a psychotherapy relationship? What does it look like that is different in rehabilitation? We have done some work trying to design structural supports to support a focus on health and wellbeing. So this Living Well Toolkit project is a project that has been going on over a number of years. The Living Well Toolkit is now available to freely download from our website, and there are a range of video resources that sit alongside that as well. And we're also really trying to explore other ways in which rehab can be delivered. So what constitutes rehabilitation? Where is it delivered and who delivers it? Does it stop when health services are no longer involved, or is rehabilitation inherently a lifelong process? And if that is true, who else has a role in supporting that rehab process? So one of the pieces of work we're doing at the moment is setting up and implementing peer mentoring services for people with traumatic brain injury, and then evaluating those to look at whether or not those services can provide something different from what health professions can. Those are just examples. We finally just last week launched a new website, so we have lots more information on our website than what we have historically had, and so feel free to have a play and look at some of the other work that we're doing as well. And so to finish, and then I promise I'll shut up. While what we do is important, this is a phrase that I used in a paper that I wrote about therapeutic relationship a number of years ago now, and Kath McPherson was the co-author on that paper, and we've used this phrase a lot, but it still holds true to me. While what we do is important, who we are and how we work may be critical to outcome. And so sometimes relying just on our disciplinary skills and competencies is not sufficient. So how do we grow those core transdisciplinary processes to optimise the way we work with people? And patient-centred and self-directed care necessitates, I think, us to focus and legitimise other processes that maybe we haven't always privileged in our practice to date. And so I think a more explicit emphasis on those core skills may be really critical to delivering on your goals. And I'm sorry that I took so long.